Good evening. I'm Jocelyn Gladhorn, Community Engagement Coordinator at the library, and we'd like to welcome you to the New Canaan Library. New Canaan Library is the heart of the community and a place to explore your intellectual curiosity. So to deliver on these goals tonight, we welcome back Stanford Hospital and Dr. Dina Ebright, our physician moderator for Med Ed in our second series. And tonight we are delighted to have Dr. Evelyn Cusack speaking to us about the heart. And now let me introduce Dr. Ebright. Thank you for coming to the library.
Thank you, Jocelyn. Good evening. This is our third lecture in the spring series of Med Ed. I see some new faces today, which is great. For those of you who I haven't met, my name is Dina Ebright. I'm a general internist here in town with Fairfield County Primary Care. I'm going to introduce our speaker tonight, Dr. Evelyn Cusack. She's going to be speaking to us about the heart and cardiology. She's a board-certified cardiologist who did her internal medicine residency at Brown University and then completed fellowship in cardiology at New York Medical College and did further training in advanced echocardiography at Columbia Presbyterian Hospital. Dr. Cusack is part of the Heart Physicians Group and sees patients in Stanford and also here in New Canaan. Dr. Cusack.
Thank you very much, and thank you for coming out on this beautiful May evening. It looks like it started out not great, but it looks like it's kind of could become a beautiful day. And I drove through your beautiful town, and it's just gorgeous. So I'm Evelyn Cusack. I'm a cardiologist, and I'm going to take you through a whirlwind tour of the heart. So sometimes you might be able to understand what we're talking about, how the heart works, and some of the diseases that might affect the heart. So I'm hoping that all my fancy stuff is going to work today. But Maria, she bailed me out again, so I'm thinking it will. And I'm going to need my old lady glasses possibly. So, okay. So I have no financial disclosures. That's what apparently we all have to do. I don't know what I would have a financial disclosure to have about, but I don't. I don't have any stock in anything. So heart disease, just a little background. It is still, unfortunately, the leading cause of death in the United States for both men and women. That needs to be hammered home until that has changed. So it is still the leading cause of death above that of cancer. So it's something that we should be aware of and something that we really can do to impact just by simply lifestyle, starting there first. Coronary heart disease kills about 380,000 people per year, and there's over 500,000, there's 720,000 heart attacks a year. And this is just a graph showing in blue, that's what coronary artery disease, that's a breakdown of deaths attributable all different things. So 48% of people that die in this nation are dying from heart disease. Obviously, stroke, I'm sorry, this is the heart cardiovascular disease, so half of them are coronary disease, I apologize. So this is how much we're spending in heart disease care. So we're talking billions of dollars, and this is projected out to 2030. And as you can see, it's an enormous toll on the American economy. And these are what the most common discharges from hospitals are. So you can see cardiovascular even outweighs obstetrical, everything. But the good news is we are declining in our death rate. We may be having as much heart disease, but we're getting better at treating it. So this is good news. Less people are dying. Obviously, 50 years ago, if somebody had a heart attack, there was a good chance this person would die before even, getting medical care. And we're much better at recognizing symptoms, treating them appropriately, and averting death. So the history of the heart, just a little background for fun. So Aristotle, back in the 4th century BC, said the heart is the seat of intelligence, motion, and sensation. William Harvey, back in 1600s, they started to understand the physiology of the heart and said it's been shown by reason and experiment that the beat of the ventricles, blood flows through the lungs and it is pumped through the whole body. There it passes through pores in the flesh, which is a little off, and veins through which it returns in the periphery. So that actually wasn't that far off. Okay. So what is the heart? Simply put, it's a muscular organ that sits in the center of your chest. Interestingly enough, I don't know if you know, it beats about 100,000 to 120,000 times per day. Enormous. The heart pumps oxygenated blood. About each pump, it's about 70 cc's, which is about a third of a cup of blood in a normal average heart. And that's about 4 to 8 liters per minute, which is 4.2 to 8.5 quarts a minute. I had to convert all this because most of medicine is done in the metric system, so I had to convert it over. So just to give it in the English system, that's what we're beating per minute. Blood moves from high pressure to low pressure areas. That's the nature of how blood flow works. So that's how it gets into that periphery. This heart generates this huge pressure, pumps it out, and then there's a lower pressure in your periphery. So that's how your blood flows to those areas. Simple physics. High pressure, it wants to go to the lower, less resistant pressure, and that's how it gets to the periphery of your legs and your arms. Oxygen diffuses into the blood through the lungs, and it binds to hemoglobin, your red blood cells. And then what that does is the red blood cell then travels through your body, and it goes to the vital organs where oxygen levels are lower. And by simple diffusion, the blood that's rich in oxygen is going to it's like, when you stir milk and chocolate milk. The chocolate's not going to, it wants to get, to go to the lower areas. So what'll happen is that oxygen, this high concentration of oxygen in the blood, gets to these tissues that have lower oxygen levels, and the oxygen diffuses into those tissues, and that's how oxygen transfer happens. So that's the premise behind why your heart is so very important. So you probably have heard of systole and diastole, or your systolic blood pressure and your diastolic blood pressure. Systole, on the right, is when the heart contracts and forces blood into the lungs, into the body. Diastole is when it relaxes. This is just as important as systole. This is when the heart fills with blood. So if you have diastole that doesn't work well, like your heart doesn't relax, then what can happen is your heart won't fill appropriately. And if you have problems with either two of these, either the pump is too weak or the pump doesn't relax, systolic dysfunction or diastolic dysfunction, you can have heart failure. Okay? So this is an important concept. Systole is the pump. Diastole is the relaxation. You spend most of your time in diastole. The pump is quick. The relaxation phase is about 2/3 of the cardiac cycle. So let's talk a little bit about anatomy. Okay, so obviously the heart has 4 chambers. We're going to talk about the left side and the right side. The left side is the oxygenated side. That's where the lungs have sent back the blood that's rich in oxygen. And on the right side is the blue blood, the deoxygenation blood. This is the blood that's come back from the tissues that has used that oxygen for metabolism. So right side of the heart, left side of the heart, and then we'll get to drill down into the other stuff. So left and right. Right heart receives the oxygen-poor blood from tissues and organs and pumps it to the lungs for oxygenation. Left side of the heart receives this oxygen-rich blood from the lungs and then pumps it to the aorta to go through all the tissues and the organs. Little side note, the left side of the heart is much more muscular because this is where all those arteries, it has much more pressure on the left side. So the left side of the heart has more, it's the powerhouse, it has more meat and it's stronger. The right side is pumping to this very low pressure system, so it's a smaller, less pressure system. And the process occurs, this process occurs with each beat of the heart, this whole cycle. So there's 2 chambers in the top part of the heart and 2 chambers on the bottom part of the heart. So the 2 chambers on the left are called the left atrium and the right atrium. And I think I got this, I apologize for this confusing little slide, I'm reading it now. So the top chambers are called the atrium. One are on the left and one are on the right. The 2 bottom chambers are the ventricles. I'll show you a picture. And the valves inside the heart are the doors, so to speak. The doors open and close, so it directs the flow of blood through the heart. With each squeeze, think about a tube of toothpaste. If there was 2 holes in the toothpaste, when you squeezed it, it would go out both ends. So one door opens so that the blood will go that way instead of going backwards back into the lungs. And you can see that on, let me just get my little pointer, see if I have it. Not sure what this is. I don't want to start clicking slides. Hang on a second. Anyway, I'll just go up. So, right atrium, left atrium. Can everyone hear me? Left ventricle, right ventricle. These are the valves, the doors of the heart. When the left atrium pumps into the left ventricle, that door closes. So when this pumps, instead of going back into the left atrium, it'll go up this valve and out the aorta. Aortic valve, mitral valve. So you can see they open and close in synchrony, so that way blood goes forward. Sometimes you may, and the same thing is occurring on the right side of the heart. The tricuspid valve opens, so the right ventricle can fill, the right ventricle squeezes, the pulmonic valve opens, and this door is closed, so it doesn't go backwards. You may hear sometimes people have had leaky valves or calcified valves. That's valvular heart disease. It's the doors of the heart that may not be functioning perfectly well. And as you can see, this is where your blood pumps to. So that blood pumps, the red is where the blood goes. And then the blue are the veins. And that's where the blood is coming back from. The blue is the oxygen poor blood. This is a much lower pressure system. The red blood is the oxygenated blood. Remember, it's pumped out from the heart. It's a higher pressure system. When you take blood pressure, you're measuring the force of the blood in those red arteries, okay? So, arteries and veins. Arteries take blood away, AA, from the heart. They're muscular and higher pressure. The veins take blood back. Remember, the tissues have used this blood. They've gotten all the oxygen they can from it. So then this oxygen-depleted blood comes back and goes around robin again to the lungs. The pulmonary artery comes off the right side of the heart. The pulmonary artery is the conduit from the right side to the lungs. It gets the oxygen. Then it returns back to the left side of the heart, where it has nice, rich oxygen, and then it's pumped away from the left heart through the aorta. Thing about the aorta, it is the largest blood vessel in the body. You've probably heard of aortic dissections. The reason that can happen is because this is the first blood vessel that the heart sees. This is where the pressure is the highest. So there's a lot of shear stress on this. This artery can dilate if it's has some pathology to it, and it's where dissections can occur because of that and other, so this is where you hear about that. And it also is what delivers blood to the rest of the body with this oxygen and all the branches of it. So, as you can see, there's the big aorta. That is, and as you can see, something else, which is going to be, I'm going to show you in a second, is these are coronary arteries. These are the arteries that come, the first things that come off this major blood vessel is the coronary arteries. This is what supplies your heart with blood. Very important. The blood that the heart is pumping is not what's nourishing the heart. There's coronary arteries that come off the aorta that nourish the heart muscle. And that's why people, and that we'll delve down into that. So, coronary blood vessels, coronary arteries, the coronaries, these are all synonyms. So there's the coronary circulation supplies oxygenated blood to the heart muscle. There's 3 major blood vessels to the heart. They arise from the coronary sinus, as I just showed you. That's the aorta, right off the aorta. And there's the left main, which splits into the LAD, or the left anterior descending, and the left circumflex. Then on the right side is the right coronary artery. Very important. If one of these becomes blocked, that can be a heart attack. So again, this is an important concept to see. And as you can see, this is the aorta cut off. Comes right off. This right coronary artery supplies this whole right side of the heart. Then the LAD, the left main, comes down. There's the LAD supplying the front part of the heart. Circumflex runs around. You may have had a heart attack in the front part of the heart because you have a blockage here. It all depends upon where your blockage is. Sometimes people have blockages in all 3 of them. The widowmaker, if you've probably heard about the widowmaker, right there. Because why? It hits the left main. It hits this and this. It hits before these things, and this whole side goes down. And what can happen is people can have complications such as irregular heart rhythms that can be fatal, or rupture the actual heart muscle, or cause some severe valvular disease because the valve also needs blood flow. So that's the Widowmaker, the left main. So it's a very dramatic name, isn't it? So again, the heart valves. There's 4 heart valves, as there is 4 chambers, and there's divides the chambers, the atrium from the ventricles, so that way it again directs the flow of blood. You want blood to go forward, not backwards. It needs to go where it needs to move ahead. So the left side has the mitral and aortic valve. The mitral is between the left atrium and ventricle. The aorta is between the left ventricle and the aorta. You'll see this in a second. It's much easier to visualize. And the right side is the tricuspid and the pulmonic. And back again. Right side, again. Think about you're facing me. So I know it seems right is left and left is right. It's like you're facing me. So this is the convention in cardiology because we like to confuse people. So we do. It's like, and we also call things like sonometers. What? It's a centimeter. We just like to be fancy. So right side of the heart. Here's the tricuspid valve, okay? Then there's the right atrium, right ventricle, tricuspid valve opens, it closes and the right ventricle squeezes, goes up to the pulmonic valve, gets beautiful lungs, oxygen, whips around, comes back into the left atrium, hits the left atrium squeezes, it fills up the left ventricle, the mitral valve closes, and then the left ventricle squeezes, and out the aortic valve into the aorta. As you can see, it's a series of doors that open and close, so that, and this to even complicate matters, these 2 things happen almost simultaneously on the right and the left side. The heart is a muscular pump. It needs to pump and it needs to move blood forward. And there's lots of things that can happen that can change that. But as you can see, it's a simple yet elegant system. And it's hardworking, like I said, 100 to 120,000 times a day. And if you calculate, I don't know how many heartbeats that is in a year. It's just way too much. Okay, so let me see if I get this. So this is now, on top of that, so we just went over the blood flow and the anatomy. Now what we're going to talk about is the conduction. So there's also there's wiring to all of this. How does the heart know to beat? It's all regulated by hormones, and there's an electrical conduction system in your heart, and it's told to go faster or slower depending upon the impulse, input. And that input is physical activity, stress, pain, anxiety, fever. There's a whole myriad of different things, and I'm going to turn that down, I so apologize, that can happen that is way beyond the scope of this, or else your heads will spin and you'll fall over. Let me just get this. Click right on it. Click right on it. There we go. So as you can see, this is my fancy bit of motion. I was so excited. So as you can see, I'll do it again. So you can see it all beats in, let's see if we can do it again. Oh, come on, baby. How do I, oh, it doesn't matter. It's not going to do it again. It's a one-trick pony. Oh, there it is. Maybe not. Anywho, it's all good. But as you can see, that electrical conduction starts at the top part of the heart and goes all the way down. And this happens continuously. So this way, when the electrical conduction starts at the top, because it wants the top part of the heart to beat first. Because I remember I told you, atrium fills, squeezes, then the ventricle fills and squeezes. Lub-dub, lub-dub. And that's what's happening. And what will happen is that, so the impulse to squeeze has to start a couple of milliseconds before in the atrium, so they squeeze first, then it travels down to the bottom, and then that's what happens. So it's like I said, it's an elegant little system. So putting it all together. So
Normal heart has 2 sides, a right side and a left side, 4 chambers, the top receiving chambers,
as you can see,
and the lower chambers.
you see it's happening simultaneously. Blood is filling, doors are opening, as you can see. Blood comes back from the brain and the bottom of the heart. It comes across the tricuspid valve. Then it goes
and ejects that blood cell
all
into a vessel called the
right into the
pulmonary
pulmonic valve,
artery.
where it travels
Into 2
to the
vessels,
lungs.
each going to the lungs.
Get oxygen rich, because remember, this is oxygen poor blood, so it's going to be attracted to the oxygen's going to be attracted, comes back over to the left side of the heart into the atrium, fills in the atrium, then the atrium squeezes, then opens the mitral valve. Mitral valve then delivers the blood, and then the ventricle squeezes up the aorta and back. And again, all this is regulated by electricity, hormonal input from physical activity, and the like. So it's a complicated little thing, but it's not as bad as it sounds. Well, anyway. So I always kind of think about it, the anatomy is like, it's like a house. So there's plumbing, there's electrical wiring, and then there's also a structure. So if the plumbing is gone, you get clogged arteries, you're at risk for a heart attack. So those little arteries that we talked about, if they get plugged up with cholesterol or damage through smoking or hypertension or some other, and then the cholesterol is attracted, that's what can happen there, clogged pipes. Any plumbers in the room, they know what that's about. Then you have the electricians. You can get too fast of heart rhythms, too slow, like ventricular tachycardia or atrial fibrillation, where the wiring's a little bit too fast and it can cause symptoms or, God forbid, death. Then you have slow heart rhythms. The heart's decided that, you know what, I'm only going to beat 30 times a minute or 20 times a minute, and these are the people that might need pacemakers. So these are the two types of arrhythmias or electrical wiring problems: too slow, too fast. Then you have structure. Do you have leaky valves? Do you have calcified valves? Are these valves not opening? And last but not least, is the heart muscle working appropriately? Is it too weak? Is it too boggy? Is it too small? Is it too stiff? So these are all the things that we think of when we're thinking about the heart. All right. So let's just we just talked about structure and function and what the heart does. That's a lot. So you have an idea of what this little beautiful piece of equipment is doing every day without you even noticing it. So what can we do? When you go to the doctor, why are they doing certain things? So we have electrocardiograms, that's measuring the electrical conduction. Echocardiograms are that ultrasound, so we can look at the heart size, the heart function, the heart valves. Then we have exercise stress tests. That's when you get on a treadmill and you exercise. So we're trying to look for irregular heart rhythms with stress or blockages. We have the stress echo. We have the nuclear. Those we're looking for, again, blockages. Then a little more new agey is cardiac CT and MRI, which we'll touch on briefly. This way, when somebody asks you about that, what's this for and that's for? So what is an EKG? It just measures the electrical activity of your heart. It can diagnose a heart attack that's happened in the past, because what happens is when you have a heart attack, it changes forever the electrical conduction of that cell. So if there's a group of cells that have been damaged irreparably from a heart attack, they're going to act electrically different, and we can see that on an EKG. That's why we do that. The other things it can see, and also can see if you're in the throes of a heart attack, because again, same thing. If your heart muscle, if that area of the heart muscle is not getting enough blood flow, it changes it electrically. And there's characteristic changes you can see on that. We're also looking for irregular heart rhythms such as atrial fibrillation, extra beats. Somebody comes in with palpitations, I can sometimes see it on the EKG. Again, we're looking at the electrical conduction because that's the impulse the heart has to beat. And then also, too, you can sometimes see if the heart's enlarged because the voltage or the spikes are much bigger. And you can say, wait a minute, and that means that the heart muscle is bigger, because the bigger the heart, the bigger the voltage. It does not tell you about if there's any blockages in the heart that are silent. So you have a 50% blockage. I can't tell that with an EKG. So if you go in with chest pain and you had it 3 days ago and everything's fine on your EKG, it's probably not adequate to say you've not had it. This is not your heart. Okay? The function of the heart, I can't tell that by EKG. I'm not going to know that. And also the heart valve problems, I can't tell that from an EKG. Okay, this is just telling me the electrical conduction, and you now know why I can see an old heart attack, because it irreparably changes the electrical way it acts. This is where the leads go. It's a 12 lead, but you can see there's about 10 leads we actually put on. And this is actually an EKG of somebody having a heart attack. That I know, and I'm going to show you one later, but basically this is telling me that the heart rate is 300, 150, 100, 75 beats a minute, and as you can see, these are high. You're going to see this, but these are elevated. I can tell by this person is having an inferior posterior heart attack, and I need to get them to the cardiac cath lab immediately to open that artery. Okay, that's an abnormal EKG. I'm going to show you normal ones when we get to that. So what is an echo? An echo is an ultrasound, a sonogram. It can diagnose weak hearts, enlarged hearts, structural heart problems like valves, abnormal holes in the heart that you're born with, for congenital, like patent PFOs or ASDs, they're fairly common. It does not tell you about blockages in the heart. It can tell you about an old heart attack because I can see that heart muscle there is weakened. It does not have any radiation. It's the same ultrasound they do for babies when a mom is pregnant, so it's very safe. And it's a two-dimensional picture of a three-dimensional object, so we need to take different views. And that's what you do when you get your echo. And in a second, this is what your echo will look like. That's a beating heart. And just so you know, this is your mitral valve, this is your aortic valve, and it's in a different plane. This is a good heart muscle. Okay, these are, it's getting a little jiggy. Okay, it's a little slow. That's not the way it looked on. Let's see. What do you think? Well, you got a good, should I click it again? Yeah, why don't you? Give it a whirl. Okay, oh goodness. We're frozen in time. All right. So as you can see, let's keep our fingers crossed that it goes through the whole thing. So this is a normal heart function. This is a good squeeze. That's 70 cc. It's getting a little jiggy. It's okay. You know what? You get the idea. I had all these beautiful images, but you know what? At the end of the day, I'm not going to give you a test on this, so do not worry. But basically, also we can throw Doppler, color Doppler. I can see whether or not the valve is leaky. I look at how well the valves are opening. I look at all the walls of the heart. Is everything functioning well? I can also see how well it's relaxing. Because I remember I told you about a stiff heart. I can tell you have a stiff heart. It's actually great. You can also look and see whether or not there's any tumors or anything like that, or blood clots within there. But I'm not going to torture you with that anymore. So let's go, because we tried. We gave it a good college try. Exercise stress testing. All right, so it's probably a fair number of people in this room have had this. What we do this for is I want to say this multiple times, we cannot directly visualize coronary arteries by stress testing. Can't do it. We're looking at the heart's response to exercise either via EKG, electrical. If it's a stress echo, I'm looking at the heart function with exercise. I expect to see certain things, and I'll get to that, and nuclear. Again, stress testing does not visualize the coronary arteries. It looks at the heart's response. I can extrapolate whether or not I think you have a significant blockage. So EKG, or it's exercise stress, or ETT. It's the electrical activity in the heart changes when there's low blood flow, so I can see characteristic EKG changes if you have low blood flow. So if I see that, I may get a different kind of test. The EKG changes are common in stress testing, particularly in women. So just the plain old treadmill can sometimes be false positive. So somebody tells you you had a normal stress test, don't think, oh dear God, I'm gonna need a stent. No, it's fairly common. Stress testing, just plain treadmill stress testing, is about 70% accurate. In women, there's a lot of false positives, so don't always assume that it's going to be the worst. We also talk about pre-test probability. If you start testing low-risk people, you're going to get false positive. This is going to cause people to get more stress testing, which they may or may not need. So we really try to reserve stress testing to people that are symptomatic, or we feel like, this person has a high risk of having a problem. So that's why sometimes all screening, that we don't talk about just general screening for stress testing. That's an important concept. There's no just standard, everyone gets a stress test at 50, okay? No, because what will happen is we're going to get a lot of false positives and possibly hurt somebody that way. It's not really that useful if there's no symptoms, so hence no standard screening. And how long you stay on that treadmill is probably one of the most important prognostic information. If you stay on 3 minutes on the treadmill versus 10, I can tell you no matter what happens, the person that can go 10 minutes has a much better outcome on all counts than a person that only can go 3. And sometimes it's hard to, we can't do them because you can't interpret the EKG because there's artifact. Exercise stress echo is a stress test with an echo. So it's more accurate than just having a plain old treadmill because I'm looking at your heart function pre and post exercise. I expect to see a strong heart. So your heart's pumping like this at baseline. At stress, it's whoop, whoop. That's what hearts do to augment because your muscles are demanding more. So it has to augment. In stressing, if I see, like here you are at rest, here you are at stress, top part of the heart's not doing anything, I'm like, uh-oh, there might be a problem to that blood vessel. That's stress echo. So I'm going to show you a picture. We'll see how this goes. Now if we get a couple seconds. Okay, you see on the right, it's like squeezing harder. Can you see that? I know, it was quick. I think that's all I got, peeps, because I don't know whether or not it's going to come back. I think it's like a one shot, and you have to, it's terrible. All right, I don't know. Apparently I'm not that good at the videos. Don't worry, Maria. It's all good. But did you get it? Oh, I have an idea. Yeah, that's a great idea. Oh, you're so smart. All right, hang on a second. Okay, so you see over here, that one looks a lot more, like it's crunching down a lot more. Did everyone see that? So I know it sounds really simple. We took extra views, but it is kind of simple. But that's it. That's the premise behind it. If I see that you augment, that heart function augments with exercise, I say, you know what, there's good blood flow. But you just can't be walking 2 minutes. You got to give your heart a good stress for this. Because you want to make sure you're out there on the treadmill giving as hard as you're going to go, and there's no evidence of any significant blockages that restrict the flow of blood that causes heart dysfunction. That's the premise behind it. Nuclear is a little different, a different way of looking at blood flow. Again, don't directly visualize the coronary arteries. I'm looking at, and it's particularly helpful when you can't exercise. Say somebody has a bad hip, a bad knee, and they need a stress test because they're having symptoms, and they're going to be able to walk 1 minute and fall off the treadmill. Well, we don't want you to go home with a big gash in your head, so we use medicine. But we also use the nuclear stress test with exercise as well, and what it does is it looks at, we take a nuclear tracer, inject blood flow in, inject the tracer in, your heart glows brightly. If your heart muscle's healthy, it picks up this tracer and makes it glow brightly. Then I stress you with either exercise or medication, and it should glow as brightly with stress. If there's an area that doesn't glow as brightly, then it means, there's not as much blood flow. And as I say, a picture's worth 1,000 words. There we go. So, see the nice donut? This is a little subtle. The donut. You see down here, this donut is not nicely filled. This should be a nice circle. Okay? The circle is not complete. It should be a nice circle. The bottom here is gone. This is a study that tells me that the bottom part of this person's heart is not getting good blood flow. Okay? And if you compare it, it looks and I'm sorry this didn't come out as well on here. If you compare rest to stress, rest, stress, rest, stress, rest, stress. I think this one tells it the best. See, this one here is a little worse. That tells me it looks like at rest there's a problem, and at stress is even worse. So that's basic. And I don't have a nice normal. This is what the camera looks like. So this is a gamma camera, and this is a nuclear camera that actually detects that nuclear radiation within the heart muscle. And this should be a beautiful golden circle, little low. And as you can see, we have a little bit of a golden circle, okay? And this should be a sideways U, and this should be an upside down U. It should be all golden. As you can see, there's areas that are not golden. So that tells me there's diminished blood flow to that area, and if this person's having some significant symptoms, I need to probably do further testing, possibly even a cardiac cath, because that's the way to directly visualize a coronary artery. And, oh, here's a little bit better. This is much better. So rest, see how it's a nice circle? Look at what happened here. Low blood flow. Whole side of the heart, rest, nice U, upside down U, all of a sudden gone. Okay? Same thing here. Sideways U, bottom part. So this is rest, everything fills in. So everything is fine here. Okay? Good, everything is, the heart's working. And then you stress this person like, okay, I can't, I'm not getting enough. Because, and so that's why the nuclear tracer doesn't get to that part of the heart. Does that kind of make sense? All right, so there's new fancy-dancy, high-tech stuff. We do CTAs. Now, the interesting about CTAs, which are CT angiograms or CAT scan angiograms, computed tomography, is cardiac CT, the calcium score. Has anyone heard of the calcium score before? Okay, so what that's looking is actually some poor slob is sitting in a radiology department measuring bit by bit how much calcium is lining your coronary arteries. Normal is 0. So as we get older, we might get more. So what they do is they made this nomogram. They've sort of gotten all these people together and all these patients, and they've tried to age match to say, okay, if you're 60 years old, most people have this much, okay? So that's how we kind of do that. Then there's another, not only the calcium score, but they also inject tracer, and they can highlight the coronary arteries. Why? You're like, well, it sounds great. This. We don't have to go for coronary cath, and we can look at what our blood vessels look like. It doesn't tell us much about function. So, okay, you have a little 50% blockage. If you can only go 1 minute on the treadmill and you're grabbing your chest in pain, that's telling me something. That's telling me a lot. It's giving me prognostic information. So you have to you have to marry function and anatomy. Okay, you just can't say, well, So this is what a CTA looks like. This is the CAT scan. Now, I know you read these all the time, so you know exactly what you're looking at. This is all lung tissue. These are all the pulmonary little arteries, not the big pulmonary, but the capillaries and all that. This is the aorta, cutting it in like this. This is the right coronary artery. Look how beautiful and smooth that is. It goes around. There's no bites out of it. There's no narrowings. It's beautiful and smooth. That's what they do. So a cardiologist will take a look at this CAT scan and look at all 3 coronary arteries. Is there any calcium in it? Which, without contrast, is going to glow bright white. And he's going to look to see, is there any areas that have little bites taken out of it? Again, it's good if you're on the fence about I'm not sure if this person really does. It's the stress test wasn't positive, but the guy's still having chest pain. This might be the next step. Not used as much, I will say. Not used as much. It's expensive. A lot of insurance companies don't use it, and you're going to be exposed to radiation as well as IV contrast. So there's always a price to pay, as you can tell. So there's cardiac MRI, which unfortunately is even more expensive and less people do it, but it's probably the best imaging that we have. It takes lots of pictures. It does take a little time in that ridiculous MRI machine. And it also can take a picture of the heart moving, where a CAT scan cannot. And it's not readily available, and it's very time-consuming, and you have to it's very expensive. And that's what it looks like. I don't read cardiac MRI, but I'll tell you. So, again, they're looking at the heart muscle, so you can actually look to see if there's calcification or some other kind of abnormalities within the heart muscle itself. It can look at coronary arteries. So it really is if you have a disease process going on in your heart that we're having trouble trying to define, like sarcoidosis or amyloidosis, again, these are things that affect the heart muscle. Sometimes we go for a cardiac MRI. So that's a really high-level kind of testing. That's not something you're going to see regularly just going to just for a regular checkup. So what are the basic things we're looking at? We're looking at blockages, acute heart attack, blockages in the coronary arteries, angina, stents, cardiac bypass, valve problems. Do we have calcified or leaky valves? Aortic stenosis, mitral valve prolapse, mitral regurgitation. These are common names you may hear. Those are the valves. Heart failure. You can have dilated, weak hearts or stiff, thick heart muscles. You can also have congestive heart failure. So these are the things these are the terminology that it's a weakened heart muscle or a heart muscle that's stiff. Basically, your heart is unable to pump enough blood forward because of various problems, dilated or thick. Then there's conduction problems, atrial fibrillation, supraventricular tachycardias, SVTs, ventricular tachycardias, palpitations. These are some of the fast heart rhythms. Pacemakers and ICDs. Pacemakers are when your heart's too slow. ICDs, if you're at risk for having sudden cardiac death. And what is that? That's a fatal arrhythmia that you could be standing there and it happens to people that have these are people that have abnormal hearts to begin with. We typically can identify people at high risk. These are typically the people that have had heart attacks in the past and their heart is very weak, or they have things that are terribly, terribly thick heart muscles called hokum. You sometimes see basketball players like, was it Len Bias? Who was the guy that had which one was it? Len Bias, young Celtic kid that was playing basketball, dropped dead, I think right before he got picked up for the draft and died. I'm dating myself, obviously. But it's funny that we see those kind of kids. They're born with these congenital heart disease, and they are at risk for sudden death, and that's what the defibrillator does. A defibrillator will have a pacemaker, but it shocks you. It shocks you if you go into those arrhythmias that can kill you. Pacemakers don't do that. Pacemakers just pick up the beat when your beat's too slow. Okay, so what are our goals for medical therapy? Why do we get our panties in a bundle? That's the thing. Why am I always yelling about statins? I'm not telling everyone needs a statin, but basically I'm trying to select the appropriate patients so that I reduce your morbidity and your mortality. That means I want you to live longer and live better. I don't want you to have a heart attack. That's what this is, goal. And it's always a changing and moving target. Okay, we always want, we say, well, statins this and statins that, and they're some days good, some days bad. I know it's embarrassing for most cardiologists. We're trying to get the best data out there. So that's why cardiologists are obsessed with trials and naming their trials funny things like the Jupiter and the Oasis and this, that, and the other thing. You probably heard about it in the news. But that's the bottom line, is that we're trying to figure out the best way to treat you. And as I showed you many slides ago, we're getting better at this. We're getting better at this not because we're doing more surgeries and more stents. We're getting better at this because we're giving better medications that are more effective. That's the bottom line. So it's lifestyle and medications that really have done the lion's share of all this benefit that we've seen in patient mortality. We want quality and quantity. Risk versus benefit. As you know, there's no medication in the world that doesn't have a side effect, including the stuff you take over the counter. Don't be fooled if it's an herb. Don't be fooled if it's natural. It all has it. And most drugs came from natural things. Remember, aspirin is willow bark. Statins came from a mushroom. So you can see most things come from that. And again, we're trying to individualize this to the patient. So it's not one size fits all. Not everyone is born the same way. Not every 60-year-old woman is the same. So getting to that, what are the basic cardiac risk factors? I'm sure everyone here probably knows this, but independent. There's nothing we can do about this. Advancing age, family history, and also too, men are more likely to have heart disease than women still. Just women are more likely to die from it when they get it. What we can do? What are the modifiable risk factors? Obviously, I'm beating a dead horse. Smoking, blood pressure, cholesterol, diabetes, obesity, and lack of physical activity. Just a little quick aside, those same things are the same risk for stroke. Stroke is a heart attack in your brain, and that is one of the leading causes of death as well, and it's, again, same thing, more men are affected, more women die from it, and it could leave you with a debilitating stroke. So if you work on your heart, you're going to be working on reducing your risk of stroke. One thing for stroke, atrial fibrillation is a risk for stroke, where it's not a risk for coronary artery disease. And this says, we're probably looking at a double bypass unless the wizard can hook you up again, which I thought was kind of a chuckle. I thought it was a chuckle at 3 a.m., maybe not so much right now. Anyway, so we talk about preventative cardiology. What does that mean? There's primary prevention and secondary prevention. Simply put, primary prevention is you haven't had an event and we're making sure you don't have one. Secondary, the horse is out of the barn, but not really. We can get it back in. So secondary prevention, you've already had that heart attack, but we're trying to prevent the second one. And we're really good at it. We're really good at it. But we also need your help because, honestly, lifestyle, and I'll beat this one too, is key. It's key, it's key, it's key. What you do matters far more than what I do. So most Americans today are being treated for primary prevention, which is good. And that's things like hypertension and high cholesterol. So Who should get a statin? Again, we just talked about this. This is controversial. They've changed the guidelines about 2 years ago. So we used to say, well, if your cholesterol's high, you should get it. Now we're not so much saying that. We're looking at who you are as an individual. Do you have diabetes? Have you had a prior heart attack? Do you have peripheral vascular disease, meaning blockages in your carotids or blockages in your legs? Do you have high-risk features? Then you add that all up, and also ethnic groups are included. People of color are higher risk for having coronary events and strokes. So there's going to be a lower threshold to start. Primary prevention is much less than the secondary. So if you've had a heart attack, it's a no-brainer. You're on it, because we know incontrovertibly that statins reduce future events. It's just, it's almost malpractice not to really try to put a person on a statin. Sometimes they get terrible muscle aches and pains, and it's really challenging. But really, when I can't get a patient on a statin who's had a bypass, a stent, or heart attack, my heart hurts a little bit, because I know that they're at risk for another one. So these I thought were very interesting. So what is the number needed to treat? So in primary prevention, I have to treat 1,000 patients to save one from their first heart attack. In secondary prevention, I need to treat about anywhere from 8 to 50 patients in order to prevent that second heart attack. So you can see I'm much more effective in secondary prevention. That doesn't negate primary prevention, because, you don't want even anyone to have a heart attack. In overall, statins reduce your risk of about 1/3 for having that second heart attack. So that's why I say my heart hurts a little bit when I can't get people on it. So. And again, hypertension, you think this is all like, well, of course lower is better. Well, not so much. So they came out and they did a study in elderly patients. Our goals for blood pressure control have loosened up a little bit, because the fear of adverse effect. If we drive the blood pressure too low, some 92-year-old lady who's about this big is going to fall and hit her noggin, and that's going to be or break her hip. So we have to make sure we balance risks and benefits, right? I mean, that's what this is all about. So I know, right? So what's our target blood pressure? 140/90 for people under the age of 60. And I don't know when 60 became elderly, but apparently it is. And 150/90 is for people over the age of 60. In Europe, the cutoff is 80, which I think is a little more appropriate. So in that gray zone, in that 60 to 80 gray zone, I look at other things. I look at, what's their kidney function? I want to protect those kidneys, because what does blood pressure do? It damages blood vessel. These delicate, beautiful blood vessel walls constantly are being pounded day after day, 100,000 times with blood pressure. You can imagine what that's going to do. They don't like that. Particularly the kidneys, the brain, and the heart. Doesn't like it. Uncontrolled hypertension, heart, kidneys, and brain. That's why we get our panties in a bundle. Okay? Now, again, we're balancing it. So we don't want, like the person that's blood pressure and they're barely walking down the street. You know what? I'll be a little permissive there. How should we treat different populations? Obviously, diabetics, people with known CAD, which is coronary artery disease. Again, we just talked about those age cutoffs. And also, again, people of color, African Americans, have worse outcomes with blood pressure. So we got to be a little more aggressive in these people, because they're going to have the strokes, they're going to have the renal failure, and it's a huge burden and cost on the healthcare system. And unfortunately, we're not doing a very good job. We get like, oh, you're probably good enough. And people, for some reason, feel like they're a failure when they have to go on a blood pressure medication. I don't understand it. And it's a battle to get people on it. Like, well, okay. It's not a failure. So it's most of the time, it's something called essential hypertension, meaning there's nothing you can do about it. However, there are a few things you can do. Watch your sodium. I'm here to tell you, probably everyone here eats too much salt. I know I do. So it's loaded in everything. You don't have to use a salt shaker to get too much salt. 2,000 milligrams a day currently is the guidelines. Of course, they'll change that, and we'll get all confused again. But bottom line, right now, for people with high blood pressure, 2,000 milligrams a day, it's in everything. Everything. Learn to look at your labels, and even in natural foods, try to get a sense. You're not going to know, even if you get the low sodium cold cuts, trust me, it's lower sodium. They're not low sodium. Okay? There'd be no way they'd be able to sit on those shelves for as long as they do if there was low sodium in there. So it's hard. So if you can get the sodium content in the food, it's helpful. Some cardiac medications can so in other words, we also select the blood pressure medication based on what else you have. Like ACE inhibitors, we love that for diabetics, people with heart failure. We love that. It does seem to really help and prevent heart failure problems, and also helps the progression of diabetes. This is a little thing. We talk all about these drugs and these medications, but the bottom line is if you need it and lifestyle and you're really giving it a try, you might have to accept the medication, or if you have really bad disease, it's going to help you out in the end. And lifestyle matters. And I'm telling you, I wish I exercised more. I'm not even going to tell you how much I exercise because you're holding it against me, because I don't. But basically, it's easy to say. I say this every day. I'm going to get up at 5 and start exercising. I've yet to do it. I've been talking about it in my head for 3 years. So 30 minutes a day. But if you get out and walk, no one's asking you to become a gym rat, but we're asking you to get out there and get that heart pumping a little bit. And we kind of know what's good and what's bad. And some people make believe they don't. What do you mean that cheeseburger's bad for me? Really? Really? The bacon? Come on. So Mediterranean-style diets, the fad diets, Atkins, paleo, it's not that they're no good, but there's really little proven benefit. We know the Mediterranean-style diet was studied in Europe. 6,000 people, compared to the low-fat diet, they did better, irrespective of their cholesterol numbers. Huge. Gluten-free, really? Try gluten-free? Anyone ever lose any weight on gluten-free? No. And most of us are not gluten insensitive. Just saying. Some are, some aren't. Okay? Oh, am I going backwards? I am going backwards. All right, so some fancy people, some celebs. So some of them I was pretty sure it was Ginsburg, Ruth Bader Ginsburg, but I'm like, you know what? But anyway, so these are people that have had sense. President Bush, Rosie, can just say one word. She's also, doesn't she look like she would probably be someone that would need a stent? She's a little overweight. She probably doesn't have the best lifestyle. Ruth Bader Ginsburg looks like she should have a very good, she's skinny. But you remember, so people come in all shapes and sizes, so don't pass judgment. It's a lot of things that you can't do to prevent this, but there's a lot of things that you can. Bypass, David Letterman, President Clinton, Larry King. These are all men that had, I think they were all triple bypass. So these are different ways to manage coronary disease. These are people in the news that have had it. So coronary artery disease, again, you have we talked about coronary arteries, so you know what they do. They supply blood to that heart muscle, and when they're blocked, bad things happen. This is a normal, beautiful gossamer-like blood vessel, smooth as a baby's bottom. Then atherosclerosis starts to happen. We get damage from blood pressure, damage from smoking, whatever the damage may be. And even if you lived your life perfectly like a monk, it can still happen. But then what happens is then what this stuff starts getting eroded, ulcerated, roughed up, a blood clot, or it can actually rupture, like break off. And that's what statins do, by the way. Statins help stabilize these nasty little pieces of business so that they don't rupture. A blood clot can form, and then unfortunately, as you can see, heart attack right down here. But this is also a slow-going process. It doesn't happen overnight. This takes years and decades to develop. So before you get the heart attack, some people may develop chest discomfort because there's, as you can see, that's a narrow little area in the second one. So when you walk, you're just walking, like, I get chest discomfort. I get a little shortness of breath because not enough blood flow is getting to that part of the heart. So your heart is giving you a symptom. Now remember, women can act a little differently. Most of the time I see women are short of breath. Sometimes they are chest tightness, but different things. But that's the progression of the disease. And when it's totally occluded, it's a heart attack. So we try to diagnose it before you get heart damage. And those are signs and symptoms, the shortness of breath and the like. Okay, and that's when a plaque will rupture. You see that little cholesterol, and there's this thin little capsule on this gloppy cholesterol. It breaks apart because maybe your blood pressure shot up, you ran up the stairs. It breaks off, a clot forms, and all of a sudden, whoop, downstream, nothing happens. Again, statins make this a harder crust, and that way it's more stable. Again, this is why statins work in people that have heart disease. So, signs and symptoms are chest pain or pressure, shortness of breath, sweaty, like, I'm getting the cold sweats. I don't feel good. Get your butt in. 911, don't drive yourself. Trust me, you'll get in faster. Nausea, vomiting, lightheadedness, dizziness, indigestion, anxiety, weakness, these are all can be, now let's just say something. If you're a little anxious, you don't have to call 911. If you realize that you just had a fight with somebody, it's not everything, but if you get a gestalt, like, you know what, something's terribly wrong, call 911 and open your front door, because you don't want them to have to bang down the door, because unfortunately, it can happen. You don't need that drama, right? Now I told you I was going to show you an EKG. So, how do we diagnose a heart attack? First and foremost, we get an EKG. Well, we can usually pretty much tell if you're having one by the signs and symptoms. So I wish this is a normal EKG. See, these are all the different leads. And can you see over here? Holy camoli, what's going on here? You see this? All those big, tall, peaked things, whereas you come over here, and it's what you see on TV. Do you see the difference? So when we see that, what we call ST elevation, we know, oh boy, things are getting bad. That part of the heart is screaming. It's not happy. It's not getting blood. And so that's what I told you about the characteristic electric changes that you can see in the throes of a heart attack. So we also can check blood. I'm sorry. You can check blood, cardiac troponins, and those are enzymes that the heart leaks out when your heart's under duress for the heart attack. And what do? We either give you clot-busting medications, which is far less common nowadays, because most hospitals can put a stent in. They call up the cardiologist and say, there's a heart attack, come in. They call the entire cath lab. While they're getting the patient prep, the cath lab comes in and they get in usually under an hour, or usually half an hour. They usually have that artery open in under an hour, okay? Time is muscle. You open the artery as fast as you can, and the heart muscle will be restored. That's the beauty of this. And that's why we are recognizing it faster. We get in like bats out of hell, and we open up the artery. That's the interventional cardiologist, not just me, the plain old regular cardiologist. So that's what they do. And if it's a lot of disease, sometimes you might need a bypass. Okay, so there's different kinds of heart attacks. The cardiac catheters, has anyone ever here had well, I don't want to embarrass anyone, but a cardiac catheterization, I'm sure most of you have heard of that. And what it is that you either go through the wrist or the groin, and you put a tube up, engage the coronary arteries, and you shoot dye. And what you're looking for is blockages, okay? And I will show you what one looks like. You get one chance at this, people. No, oh no. Oh, Lord. Okay, here we go. All right, so this is the catheter. This is the catheter. This is the left coronary artery. Engage the left coronary artery and fill. This is a normal coronary catheterization, by the way. So he's panning and looking at all the blood vessels. What would happen in a heart attack? Oh, this is actually looping for some reason. There would be a cutoff right there. So in other words, the blood was you would just see a stump of a vessel. It would be like, oh, what happened here? So that's what happens in a heart attack. So that's all they do. They go in through the groin. Oh, so there we go. And they inject the blood vessel. And they inject all 3 blood vessels to see what's going on. And you can put a stent in. That's what a stent does. So you have this terribly block. They put the wire down in. Then they have a little tube that they expand, push it open, and leave that wire mesh tube. See what it looks like over here? That's what a stent looks like. So here's your gummed up blood vessel. They blow up with it. The wire mesh tube is just crimped down like balled up aluminum foil. They expand it with the balloon, and then they deflate the balloon, take it out, and so this provides like a scaffolding to push back that blood vessel and the cholesterol, and blood flow is resumed. Takes all of 20 seconds. It doesn't take 20 seconds to get it in, but it takes 20 seconds to blow it up, and so, it's done. Blood flow is restored. The caveat here, though, is you got to keep that stent open, okay? So you need a strong antiplatelet. You don't want your blood cells to say, you know what, this is a foreign piece of material. What the hell is this? I'm going to get rid of it. And it starts to attack it. So that's why we use Plavix. That's why we get our panties in a bottle. You have to take your Plavix, okay? Don't stop it unless you talk to somebody, okay? Because bad things happen. Now, granted, people, there's side effects, as always. So you can bleed, blah, blah, blah. and aspirin too, yes, I heard the aspirin, but the aspirin is indefinitely. Plavix, Effient, or Brilinta, if you've had a stent, are going to be, now there's new guidelines for 3 years. I know. But then after the 3 years is over, you can go back to just plain old aspirin for the rest of your life. And this prevents blockage, because like I said, your body sees this as a piece of like foreign material. It's like, what is going on? It wants to get rid of it. So we now, the block-up rates are so low, but if people stop it, we've had people come in and they're having a heart attack in that stent again because it's shut down because of so it's really very important. Okay, bypass graft is you take it either from the veins in the legs, arteries in the arm, or even an artery up top here. And what you do is you provide a detour. So this is for people that have a lot of disease or in all three vessels, or people that are high risk, like diabetic that have a lot of disease. What they do instead of, you got to put here. Now, what we do is we take an artery or a vein, and you say, here's the blockage, we reroute blood around that blockage, okay? So that way blood will come here and stop, blood will then come around and up from behind, so the whole artery is blood. Some is backfilled, does that make sense? What a bypass does? So it just reroutes the blood around that blockage because typically it's in a patient that has a lot of blockages, and we don't want to put stents in everything because if you have that many stents, you're at increased risk of having, one of those stents blocking up, and sometimes the blood vessel's too small to do it in, and so the surgeon and the cardiologist will look at the films together and say, you know what, this person is going to have long-term outcomes that are much better with bypass. It's a complicated decision. So that's what a cabbage looks like. We call them cabbage, coronary artery bypass grafts. Fancy. So now you're in the know. And also, by the way, it's not angina, it's angina. That's what we say too, just so you know. So if you say angina when you go in, you're like, oh. So what are you, doctor? So little new thing. So that's the bypass. So just one last note. You can have atypical presentations. Women a lot of times are atypical. Diabetics a lot of times, but anyone can be atypical. So that's why we have to really have our ears out. But the clinical pearl here is most of the time they start with exertion. So the vast majority of symptoms work with exertion. That's how they start. So, every time I walk up the hill now, I'm getting a little short of breath and a little chest tightness. I don't think it's anything. Or getting a little dizzy. I start like, what? What are you saying? That's what, of course it could be other thing. Asthma could be kicking in. But then when I hear exertional symptoms, I start getting concerned. Okay? And these are our congestive heart failure peeps. Danny Kaye, Elizabeth Taylor, she died of heart failure. Ginger Roger, which I think a few people in this audience may remember. And probably Danny Kaye as well at St. Jude's Hospital. He started that, Good guy. Thomas. God damn it, you're right. As soon as I said it, I realized I was wrong. Okay. All right, so what's congestive heart failure? It's a condition in which the heart cannot pump enough blood to meet the needs of the rest of the body. Heart muscle can be weak and dilated or stiff and thick. Remember I told you, sometimes it can't pump well. Sometimes she's giving me the high sign to get cracking. I have like 5, I saw it, she's coming over. Okay, so do you want me to give me, I probably am almost done. Is it okay to get another? Perfect. All right. So just a little note. So you remember, heart failure can be because you're weak and you're floppy and flabby, the heart, or it could be it's stiff and it's not filling right. It's pumping strong, but it's not filling well because it's not relaxing. Equally as important, systolic, pump is weak. Diastolic, pump is stiff, no good relaxing. Systolic heart failure, diastolic heart failure. So if somebody says, well, I have a normal heart function, why do I have heart failure? It's because your heart's stiff. It really, actually, interestingly enough, that diastolic heart failure would really start to become appreciated probably in the early 2000s. So we're finally appreciating the importance of this, and it causes a lot of heart failure admissions in the hospital. The 20th century was about heart attacks and pacemakers. Now it's all about AFib and heart failure. That's what people are coming in with. People are getting heart failure probably because they're surviving their heart attacks, so their heart muscles are weak. They're also living longer, so the effects of high blood pressure make that heart stiff, and they have diastolic heart failure. It all makes sense. It's all interconnected. The number one reason for admission in the hospital in the U.S. is congestive heart failure. So, and it's not pleasant. it feels like you're drowning. You can't catch your breath. It's terrible. So we deal with it with diuretics, water pills, and the like. So heart attacks can cause it. It makes your heart muscle weak. Valvular heart disease, if you've had long-standing leaky valve, your heart starts dilating because it doesn't like that extra backward flow of blood. High blood pressure, your heart gets stiff. If you drink a little too much alcohol, your heart can come weak. It's called alcoholic cardiomyopathy. So just as a little side note, 1 glass a day for women, 2 for men, and it's not a 10-ounce pour for wine, it's a 6-ounce pour, just remember. Because I do an 8-ounce pour, just saying. So, infection. Interestingly enough, viral infections can, and also sometimes bacterial infections can cause your heart muscle to become weak. A lot of times they get better, but they can be lasting, so they can make you have to be a transplant. Chronic disease can do it, just like end-stage renal disease, people on dialysis. Your heart doesn't like the bad humors. Genetic, and sometimes it's unknown. Or why you got it. I mean, sometimes it's familial. Sometimes we're just like, I have no idea why your heart's like this. So I've done every test under the sun. Vitamin deficiency can do it. Sometimes thyroidism can do it as well. Oh, and the one little thing that I forgot to mention here, sometimes stress can do it. It's called a broken heart syndrome, Takotsubo. So when you've maybe heard a person that say they had a heart attack after they heard a loved one passed away. Well, what the theory is that there's an outpouring of adrenaline. It causes, they're not sure what it is. Is it a spasm of the blood vessels? Is it the toxic release of adrenaline that's too much? But people come in with what looks like a heart attack. They do a coronary angiogram. The coronaries are clean. It's the tip of the heart that's blown out, and in about 1 month, everything gets better. It's bizarre. It's called Takotsubo's, or broken heart syndrome. So, but, and also there's other reasons, but that's long. And so, shortness of breath, trouble breathing when you're laying down, that's called orthopnea, when you lay down and you can't breathe, swelling in the legs, fatigue. If these things are happening and you're with a loved one, you're like, you know what, maybe we go to the doctor and get this checked out. It could be heart failure. Treat the underlying cause. If there's an underlying cause, if you have, coronary disease or what have you, medications, they improve outcomes. They really do. No one wants to take them, but beta blockers, it slows the heart rhythm down. It keeps the work of the heart less. ACE inhibitors, water pills, aldosterone. And when it gets really bad, there's machines that we can use, LVADs and transplants as well. We can transplant hearts, as you know. So that's an LVAD. Kind of cool, isn't it? Well, not for the poor soul that has to have it, but that's an artificial heart on the right, and on the left, what happens is they put these 2 little ports in the heart, and this is your heart pump. This is what pumps your heart. And you walk around. Typically, an LVAD historically has been used for people that are awaiting transplant, and so what they do is, like, and unfortunately, there's not a lot of hearts that are available, and there's a lot of people that need hearts. So what they do is they put an LVAD. It's called a left ventricular assist device, and they use that while they're awaiting the transplant to come through. So it's an amazing technology. Pacemakers, Kirk Douglas. I think that's Ted Williams. I'm pretty darn sure. The best baseball average ever, I think my father-in-law just told me. And I know Elton John. So it protects against a slow heart rate. It's not going to shock you. If your heart's too slow, it'll pick up the pace. And also, too, it's you have to be symptomatic. I mean, some people just are born with naturally low heart rates. That doesn't mean you need a pacemaker. ICDs, or the defibrillators, they protect against very fast heartbeats. So if you have an underlying, like if you have a very, 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 very weak heart muscle, or you have some other disease that increases your risk for having something called ventricular tachycardia or ventricular fibrillation, again, outside the scope of this, they're going to put a defibrillator in you. And it's going to, if you go into that fatal rhythm, you're going to get a shock, and you will feel it. But it'll shock you and save your life. All defibrillators today have pacemaker backup, so if you go too slow, it will pace you. All pacemakers do not have defibrillators, if that makes sense. Okay? And that's what it looks like. So it goes up most of the time in your left chest, because most people are right-handed. And what they do is they snake it through the vein, comes down and sits in the right atrium and in the right ventricle. Right atrium, so it tells the top part of the heart to beat. The right ventricle, so it tells the bottom part of the heart to beat. Love-dub, love-dub. It watches and waits, and watches and waits to see if you need a beat. okay? And it's your guardian angel sitting inside your chest. The defibrillator is a little bit bigger. The pacemaker's on the top. The defibrillator's on the bottom. It's a little thicker. And the same thing happens. The defibrillator watches and waits. If it detects an irregular, specifically irregular heart rhythm, it's not all, it says it starts charging up. If it doesn't stop automatically, it zaps you. And most of the time, people will land on their hiney. Sometimes they don't, but they know. It feels like my father had one, and he says it felt like a horse kicked him in the chest. He said, I think my defibrillator went off. I'm like, you'd know. And sure enough, he did. So it's a life-saving device. It really is. And it has saved many people from sudden cardiac death. And sudden cardiac death is just a fancy way of saying, my heart stopped, and it needed restarting. These are people that have had aortic stenosis. That means the valve is calcified in the aortic position. We all know Arnold Schwarzenegger, Barbara Walters, I think just had it, I think in November. And the late Robin Williams. So basically, we detect that by echocardiogram, also cardiac cath. It can have chest discomfort, shortness of breath. Why? Because that valve is not opening. It's doing this, it's going, and it's not doing, a valve should open like this. So all the blood that's in the heart can easily get out. If it's just, if the door's barely opening, it's really hard to blow. So it's the heart, the people are struggling because there's not enough blood flow going forward. The heart's struggling to beat against that. So timing of surgery is typically with symptoms or how bad, how much pressure is across that valve. Chest pain, shortness of breath, and unfortunately, passing out. And there's fancy ways to do this. So that's what, oh, beautiful. This is like I said, normal valve, opening wide, all the blood's going out. I'm barely opening. I can barely get, so you can imagine, you know, you're just beating 1 time a minute. It's 1 time a second. It's hard to get that enough blood out when it's barely opening. So that's what it looks like, pretty picture. That's what it looks like to the surgeon when he's replacing it. It's barely opening. It's all calcified. It should be gossamer thin. There's different kinds. There's mechanical valves and there's the pig valves and the cow valves. And it's done open heart surgery typically. However, fancy new stuff, we can do it through the groin. And those are reserved currently for people that are too high risk to have their heart, to have open heart surgery. The indications, it's been around successfully probably about 10 years, really going at 5-ish. But what they do is they go in through the groin, they bring that valve up like a stent, and they balloon it open while you're on, and it's amazing what they can do. But typically, very frail patients that they feel that would not do well with surgery on bypass. And it just, the balloon you can see. I think maybe we'll stop at AFib, but AFib is it's a huge burden on society. AFib, it's not a burden, like that's tough, but it's really impacting society. It's an irregular heartbeat, and the older you get, the more likely you are to have it. Xarelto? I'm sorry? Oh, I'm sorry, I thought you were asking me something. When you have AFib, you're at high risk for a stroke. That's the big thing here. You take strong, real blood thinners to reduce that risk of stroke, but it's at the cost of bleeding, possibly. Coumadin is tried and true. It's been around for ages. Yes, I know, it's rat poison. Eliquis, everyone says it, like I know, but it's a good drug. Eliquis, Pradaxa, Xarelto, Savesa, they all are the new ones. The downside currently is that we don't have, A, it's not been around, so we don't have as much data, but B, there's no antidote. So if you come in a car accident or you're bleeding, we just have to wait it out. Typically, it's okay, but it's a pause for some people. AFib, you want to control the rate or get them back into sinus rhythm. Even when you're in a regular rhythm, you still need your blood thinner because you can slip back in anytime, and that still increases your risk of stroke. Those are some of the medications: beta blockers, calcium channel blockers, and digoxin. A little note about digoxin: nobody really uses it anymore. There's new studies out there that it increases the risk of mortality, so we're trying to steer clear of digoxin. And we also have the fancy ablation. So what they do is they put catheters up there because most of AFib comes from the left. This is the hot spot right here. They take catheters, they burn with radio frequency, or they burn with cold, and they sequester where most of the AFib is coming from, and it's gone. But currently, we're still putting people on blood thinners after that. So this is the poster child for heart disease. He was a smoker. Is a smoker. He's still around. 5 heart attacks, atrial fibrillation, bypass and stenting, defibrillator, left ventricular assist device, and now finally a heart transplant. So he's done it all, the poor guy. I mean, yeah, right? Huh? I mean, and look at that. And how old is he now? My God. He must be, how old is he? Does anyone know? Is he only 72? No. Really? He cannot be. Well, anyway, so this is a man that, this is a guy that has survived it. So the take-home message is the heart is a muscular pump. It's like your house. Plumbing, wiring, take care of it. Lifestyle choices that impact outcome. Woo, that was a Freudian slip, huh? They matter. They matter more than you can ever know. So live longer, feel better, exercise every day, eat less, make better choices. Now, some people in this audience don't need to eat less, so please don't take offense to that one. And thank you and be well. Now, any burning questions that anyone may have? Yes. Yes.
Is housework considered exercise?
Well, it all depends upon the housework now, isn't it? If you're exercise is getting your heart rate up and keeping it up. So honestly, people say gardening is exercise, but if you're sitting there leaning over and really not doing much, I mean, I think you really have to get that blood pumping and keep it pumping for at least 15 minutes. But are you going up and down the stairs? Okay, up and down, up and down, up and down without stopping. And then what do you do in between going up and down stairs? I think it's great that you do it. I think you need still to walk. Okay, I do. But you know what? I'm going to tell you one thing. It's far better than sitting and not doing it, because that is physical activity. But really, you want to get a little bit more structured. Go out and take a walk for 15 minutes, because up and down, because what you're doing is you're going up, you're going down, and then you're kind of, your heart settles back in. That's 10 seconds. Oh, that's 20 seconds. Then it settles back in again. Then you want to get your heart up and keep it up to really get going. Okay? So that was a good question, and I get that a lot. And your second question is?
What causes high blood pressure?
Whoa, that's a complicated question. Now, the bottom line is, as we age, our blood vessels become less compliant. What does that mean? They become stiffer. They don't respond to stimuli as well, so they don't relax normally, and what happens is our blood pressure goes up. Some people, it's genetic, and what it is that there's hormones around that keep our blood vessels stiffer. Also, atherosclerosis can cause our blood vessels to become stiffer. So there's no real true cause of it, but we know that smoking can increase blood pressure, again, for that very reason. I've seen stress increase blood pressure, so what can you do about it? Like I said, I feel people feel like I'm personally assaulting them when they say blood pressure. And I'm like, no, it's just what it is. So you do everything in your power. What I say when I first diagnosed someone with blood pressure, I said, let's talk about lifestyle. And one of the things that the hardest thing to do about blood pressure and lifestyle is stress. Stress raises blood pressure, and people that have type A personalities typically have higher blood pressure, and people come in and they're all anxious and nervous, their blood pressure skyrockets. So they can say, well, I'm just stressed out. I'm like, well, I know you're stressed out here, but aren't you stressed in other times of your life? So we really got to get that, maybe biofeedback, maybe meditation, so that's a huge thing. Sodium in this country is a huge thing. Inactivity. Physical activity, blood pressure rises with exercise, but for the next 12 to 24 hours, you get lower blood pressure. Weight loss, you look fine. You do not look like you need to lose any weight. Weight loss can help too. Weight loss can drop your blood pressure by 5 or so points. All of these things are modest improvements, but working together, you may get 10 to 15 points altogether. There's a new study out that caffeine really doesn't impact blood pressure as much as we like to think. So I'm not saying drink 10 cups of coffee a day, but having your cup of Java, as long as it doesn't bother you, like cause palpitations, have it. Good emotional support in your family. Again, all of these things matter. But if at the end of the day you've done everything and your blood pressure's up, it's essential hypertension. Sometimes there's blood pressure problems because you have kidney disease. Sometimes you have secondary causes, but they're rare. rare, rare, rare. The most common things is it's genetic, and most of the time you have a family history of it. Okay? Sorry. Yes.
I'm a little confused about statins.
Yes.
I always thought that it involved like lowering the production of lipids in the body.
Oh, it does do that.
But then I heard you talk about affecting the surface of existing lipid deposits in the arteries.
So statins work in what we call pleiotropic ways. Yes, absolutely, without a shadow of a doubt, they lower cholesterol. They reduce the production of cholesterol. But what they also do, this is why the studies, all the big thinkers in cardiology think that statins reduce coronary events, is not simply by lowering cholesterol, because if that was the case, no one with low cholesterol would ever have a heart attack, but people do. What it does is it lowers inflammation, so less inflammation in those blood vessels, less attraction to those inflamed sites. Also, it stabilizes existing blockages by hardening that shell and stabilizing existing blockages so they're less likely to rupture. Lowering cholesterol so there's less cholesterol around to build new ones, and it can sometimes even regress old ones. So it works in multiple different ways. So it's not just about the number. So that's why a person that's had a stent, had a heart attack, had a bypass, people say, well, my cholesterol's great, I don't need this. Well, no, that's not quite true, because, as I said, the statin does a lot of different things, and it's almost malpractice not to put somebody on a statin that's had a cardiac event, because we know their outcomes are much better and they're less likely to have another coronary event by at least a third. Okay, does that kind of make sense?
Yeah, it's a very complicated
It is.
impact.
It is. And now I'm not going to say just because you have high cholesterol, I mean, they changed the guidelines. If you just simply have high cholesterol, we don't say, yeah, you need to be on a statin. We say, okay, let's try to get this down. And I have people with a cholesterol of an LDL, the bad cholesterol of 160. They're young, healthy women. I'm like, exercise, eat right, take some plant stanols and sterols because they can lower it naturally, and that's fine, because your risk of developing coronary disease at this age and at this time is not great, and statins have side effects, and you're not going to derive a benefit from a statin. But if you have known coronary disease, you will derive a benefit, okay?
You just said to take, what did you just say to take?
Oh, plant stanols and sterols.
What are
Those come from pine bark. And what it does, it's a pill that you take you can get it at GNC, you can get it at a lot of different nutritional places. I actually even think that they're at Costco. And what it is, it's derived from pine bark, and you take it about 30 minutes or a little before eating your big meal. And what it does is it binds to the triglyceride receptors in your gut. It makes it less likely for you to absorb the triglycerides. And I have had people, just last week, a woman with a triglyceride level of 300 went down to 183 on plant stanols and sterols. She takes it half an hour before her dinner. Plant, P-L-A-N-T, stanols, S-T-A-N-O-L-S, and sterols, S-T-E-R-O-L-S. A brand that I'm aware of is Cholestoff, but you can go into any Mrs. Green's or what have you. And actually, the American College of Cardiology also recommends it for lowering of cholesterol in people that are not high risk for having, like, in other words, I would not say, oh, take the plant stanols and sterols if you had high risk factors or a known coronary or peripheral vascular event or diabetic. I would say, you know what, you need a little more than that. You can still take the plant stanols and sterols, but these are high-risk patients that need that other benefit that statins confer, which plant stanols and sterols don't have, but they definitely do lower cholesterol. Yes?
I've also heard recently that Lipitor or statins can cause higher glucose or pre-diabetes.
Well, the conventional wisdom about that is more that it unmasks the diabetes in people that are like, so yes, yes, people that are on these certain medications, they seem to have higher sugars, some of them, but it's not universal, and it seems that it's an unmasking. And even with that, unmasking people that are kind of going that way, but even with that, they have found that these people, even with their higher sugar levels, have lower cardiac events. So it's a complicated question. It really is, and I get that question a lot. So that's why you don't put statins on every Tom, Dick, and Harry that you see. You reserve it for people that you know are going to derive a clinical benefit, reduce morbidity, reduce mortality. That's the end point here. Who's going to benefit from saving them from their next heart attack?
recommend for reducing inflammation?
Well, that's a good question. It's, inflammation comes in very many varieties. So, are you talking about inflammation in your joint? Are you talking about, is your cardiac CRP elevated? Or you have a person with autoimmune? So that's a kind of an interesting question. People don't necessarily say take an aspirin every day because there's risk with aspirin, isn't there? The FDA said to bear aspirin. No, you may not label your aspirin that way. Aspirin is a way to reduce inflammation. That's why people use it when they have known coronary disease. So not every person can get that. How do you lower inflammation? Lifestyle. Exercise lowers inflammation. Eating a cardiac healthy diet. There's antioxidants that lower inflammation, like the deeply colored fruits and berries. The getting as close to the earth as possible. We know that inflammation rises with stress. I mean, it's not sexy, but the reality is trying to live as healthfully as possible. And some people that have autoimmune disorders, or other people, they're just wired with a higher level. And these are people probably, we know this for sure. Remember, you've probably heard of cardiac CRP. We used to measure it all the time. It's a measure of inflammation that's cardiac specific. It's a marker for increased risk of heart disease. So inflammation is huge, and unfortunately, there's not a great pill to take it and say, just take this pill. There's always a trade-off. So the best way to do it is through lifestyle. In selected patients, aspirin may be, if they're high risk, terrible family history, a little bit of diabetes, cholesterol, hypertension, even though they haven't had a heart attack or a stroke, they may benefit from an aspirin a day. And the other thing I'm going to say, it's a baby aspirin. More is not better. More aspirin just increases your risk of having a bleed, and they can cause GI bleeding. My father, who I use as my inspiration, had a major GI bleed because he would pop his full dose aspirin, this is years ago, on an empty stomach every morning, and then he wound up in the hospital with vomiting up coffee grounds, which is, yeah, you know what that is. So they're like, But he went back on his aspirin, and he ate, and he did it the right way, and he was fine, and he did that for years with Coumadin, mind you. Yes, young man.
I have 3 questions. You may answer any of them.
Okay.
The first question is that if you go and have a nuclear stress test
Yeah.
that shows abnormality,
Mm-hmm.
and then your father had a cardiac catheterization, which shows normal clear arteries,
Mm-hmm.
is it a false positive?
Yes, exactly right. Because as you know, we don't directly visualize blood vessels, and this is the risk of testing people that are asymptomatic. You can have false positives. So that's why routine screening for asymptomatic people that are not high risk is not indicated. We put them through these tests, they have radiation, they have whatever, and then then it's abnormal. Then they have to go to the next test, and that test is not benign. A cardiac catheterization, you stick a catheter into an artery, you can have bleeding and infection and blah, 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 blah. So that's what's called a false positive. The test was positive in an abnormality, and it was falsely positive because we did the gold standard, which is the cardiac catheterization.
Second question is the amount of, say, cholesterol medication. Does it matter how much you take so that you don't elevate your glucose?
You're talking, you mean to say the glucose? I think, yes, it does. The higher doses are associated with the elevated blood sugars. But unfortunately, we only use high-intensity statins or high-level statins in people with known coronary disease, and the data is, again, so strong about people that have known coronary disease. When they use the higher doses, they have significantly lower recurrent events of death, heart attack, and stroke. Okay?
The last question is
Yes.
what blood pressure reducing medications do to lower the blood pressure?
What do they do? How do they work?
Yeah, how do they do?
Oh, there's lots of different ways they work. It depends upon the class of medication that you use. Like ACE inhibitors vasodilate. Diuretics reduce the water volume, so you have less pressure because the volume goes down. Beta blockers slow the rate of the heart and the contraction. So it all depends. And you choose your blood pressure medication based on your patient. If they're a diabetic, you're going to use an ACE inhibitor or an ARB because that can help prevent kidney damage from diabetes and also can help progression of the diabetes. People with heart failure, ACE inhibitors and will also help that remodeling. Beta blockers for coronary artery disease, diuretics for people that have diastolic, the lower number. So it's all different ways because You could have a 2-hour lecture on high blood pressure and how it works and how we treat it, and you still would probably have a million questions, and I probably would too. So that's a very good but complicated question because there's a lot of hormonal interplay in how blood pressure works. So, and that's how these blood pressure medications do work. Okay.
Thank you.
Oh, you're welcome. Any other? Oh, yes. We used to talk about homocysteine levels. We got away from that. Why? Homocysteine levels were associated with higher rates of coronary artery events. So there's a risk factor for the progression. However, so we said, oh, we'll fix this. We'll give these people with high homocysteine levels folate. Yay! What happened? Nothing. No, there was no benefit. We were giving everyone folate, and it did not improve outcomes. So we still know that homocysteine is possibly a marker for increased risk. And folate should lower homocysteine levels, and it does, but it doesn't appear to have a significant impact in lowering the cardiac event rate. There may be something else that we're missing in this whole thing. Even with that. And so yes, yeah, I mean, but you see what I'm saying? The treatment of that with so we used to do it about, what was it, 2001, 2005, around there. We were giving everyone folate and methylfolate, but it really wasn't. Certain people do need folate. Certain people that are on certain chemotherapies, certain anemias, but the data doesn't support improved outcomes. The homocysteine level goes down, absolutely, but it doesn't appear to impact reducing the cardiac event rate that has been able to be established. It's significantly. Maybe there was a trend, but nothing significant. Okay? Yes?
I thought the target blood pressure had lowered from 140 over 90 to lower than that.
It did, and then it went back up. The JNC 9, I think it was, JNC 8, it came out about a year and a half ago. And so what was happening is we were getting real aggressive about blood pressure. Lower is better. And then we were finding that people were having side effects from the drugs, people getting lightheaded. So we lightened up about that with the elderly population being considered 60, mind you, 150, right? That's just egregious. It was 150 over 90 or below, so you want them to be in the 140s. And for people below that age, you want them to be in the 130s, and the diastolic below 90. Okay, yeah, but you're right, we did. And then we loosened up. There's a lot of controversy about that, you understand. Not everyone's adopted that. Because some doctors feel, and also too, don't forget, you don't use those goals for diabetics, people with kidney dysfunction, because really lower is better for them. We want to protect those kidneys and protect those delicate blood vessels in those people. Yes?
One more question.
Yes.
When you take aspirin, like your father did,
Yes.
had
The bleed.
bleeding, GI bleeding, if you take baby aspirin and you develop a GI bleeding and they stop the aspirin because, what is the replacement? Do you take aspirin?
Well, a lot of times we don't stop it for good. You get a GI evaluation, and they help us figure out, well, first of all, you balance the benefits to the risks, right? So you say, is this person really need this aspirin? Are they deriving benefit? And then you say, well, if they really truly are, then and the GI doctor says, this was an isolated incident. Why don't we use this to protect the stomach and the like? So it's a balancing act. That's really, unfortunately, with medicine is, you're always going to have a potential risk. Now, if a person doesn't really need the aspirin,
How do you know if it needs it or not?
we talked about, remember we talked about people that have high risk or known coronary disease. So people with diabetes, known coronary disease, bypasses, stents, peripheral vascular disease, or significant risk factors for the development of coronary disease. That's a conversation you have with your doctor about that.
Which doctor? GI doctor?
No, your primary care doctor, whether or not you would be someone that would derive benefit. If you had a prior stroke, you should be on it, depending upon, of course, the kind of stroke you had. If it was a bleeding stroke, no. If it was an embolic stroke, possibly yes. But it's a complicated question. It's like sort of saying, well, everyone here should be on an aspirin. No, you need to talk to your doctor about if you're someone that would derive benefit from aspirin. Yes?
Did you say aspirin should not be taken on empty stomach?
I always tell people to take it with food. Okay? That's what I always tell people. And if you have a history of bleeding or a history of ulcer disease, you really need to talk to your primary care physician about whether or not you're someone that would derive benefit from that. Again, There's even stuff over the counter. More and more stuff is over the counter. We got to be careful and aware, and just because it says it's natural or herbs, they can be just as harmful. So, you know, be skeptical about anything that says it'll do this and it'll do that. Vitamins can be toxic, okay? Yes?
If smoking cigarettes is harmful for, heart health, can we expect that people who smoke electronic cigarettes and marijuana are also going to have?
Well, definitely marijuana. Definitely marijuana. I was not happy when they decriminalized it personally, but because I don't believe it's going to improve. I don't think it's going to benefit anyone in society except for the moneymakers. But it definitely, marijuana smoking is definitely associated with an increased risk of coronary events. Absolutely. The electronic cigarettes is an interesting question. I'm not quite sure what the data is on that. I think they're too new to see, and I don't think they've been real controlled study trials. And I think, unfortunately, the bloom is off that rose because people aren't coming. These were supposed to be a smoking cessation aid, and they're not panning out. People are just going to them and using them. So long-term effects of these things, we have to see how they go. It's a really good question, because there's still that nicotine. It's not, the one thing I will say, the tar is not in them, so I'm not sure if that may be part of the whole pathogenesis of coronary disease and the inflammation, but I can't imagine inhaling whatever's in them is gonna be good for your health long term. Like I said, it should be used as an aid to get off of smoking, not as and marijuana definitely has been shown to increase the risk of coronary disease, coronary events. And I think that's it.